Thank you for joining us at Phacilitate's digital platform. We're here in Miami at our annual event, and I'm delighted to be welcome here with Naomi Aronson, Executive Director for Clinical Evaluation, Innovation and Policy at Blue Cross Blue Shield Association. Thank you very much for joining us.
Oh, thank you. It's my pleasure.
So I just want to ask a couple of questions today. Obviously Blue Cross Blue Shield are a very interesting organisation, and advanced therapeutics obviously coming to the clinic. You lead the clinical effectiveness and policy engagement at the organisation with government and regulatory agencies and policy. How do you reflect on how Blue Cross Blue Shield's Centre for Clinical Evaluation has evolved over the years in its practices and engagement with these advanced therapeutics?
My own role has, as you know, most recently focused on policy and in an advisory scientific role to the center itself. And I think very importantly, I would say our circle has broadened over the years. Mm-hmm. Our circle of communication, our circle of reaching out. Let me describe when I began to work with the Blues, with Blue Cross and Blue Shield mm-hmm. Association. Our clinical evaluation, it was rudimentary. It was a small information sharing program. We grew, as you know, into the Technology Evaluation Center, very much respected for the work we do. Over the years, we have expanded our outreach, first by making our assessments available, and now most recently in a product and platform called Evidence Street. We call mm-hmm. it where evidence meets the market. And the beauty of this is we are now able to share all of our information mm-hmm. that we develop for our 36 plans, who collectively have 106 million beneficiaries. Mm-hmm. We provide the clinical effectiveness reviews for all of our plans. They independently decide their medical policy, mm-hmm. but we provide the core analysis and review of the evidence. Mm-hmm. And heretofore, we were able to share only our flagship assessments, which were probably a dozen or so a year. Mm. Now we're able to share our full range of approximately 300 reports mm-hmm. that we maintain annually for the plans. It's a subscription service, and it has been highly, very good uptake mm-hmm. by industry, both device industry and pharma, biotech sectors, mm-hmm. as well as bringing on some clinical specialty societies, broadening our reach in that respect. And what I think is so terrific about this is really being able to share all that evidence. Mm. And as we use it and as our plans apply it in their decision making, it makes it much more open, much more transparent. Mm-hmm. And another way that we have broadened our circle, broadened our reach, mm-hmm. is what I like to call proactive technology assessment. Mm-hmm. It's got multiple dimensions, and we're not fully developed there yet, but we are on the road. And one important service we provide to our subscribers is what we call a gaps report. Mm-hmm. That is, if the evidence was insufficient on a technology for which they made a submission, we will provide a report of what the gaps of those evidence are. And I am particularly excited because I'm currently working on a white paper which we will disseminate for comment probably in February among our subscribers and others important in the evidence medicine and evidence-based technology assessment world that describes how we apply evidence, talks about what types of evidence are relevant, consider, for example, outcomes and outcomes measures, talks about the methodological issues we address, and I think this will also reach further for our transparency. And we will be looking for comment because we want to be clear. We want sponsors to understand what we are looking for. In addition, we've had a pilot ongoing with Harlan Krumholtz's Joe Ross at Yale, where several sponsors, and again this is on a pilot basis, have brought their gaps report to that group for a consultation on what steps they might take next to fill their gaps. And we will see how that evolves into a permanent program, and I expect there may be other academic centers that will become involved, but it's the principle of proactive sharing of information. Many of the things that become gaps or frustrations for sponsors later on are quite predictable at the time when studies are being developed. So it would be better to give that feedback
Absolutely.
Up front, early.
Yeah.
And we've also engaged with the FDA. They have a program, now this is on the device side, not the pharma side, but a program where sponsors, it's quite new, can invite selected HTA groups or payers. The FDA has a list posted to be involved in the pre-submission conference with the FDA and give feedback then. As at this point, I'm not aware of a program extant on the pharma side, which might be of broader interest to the Phacilitate audience, but I just offer that as our commitment to communicating earlier. So again, as I look at how we evolved, I think our scope of audience has widened, our scope of information that we communicate has broadened, and our attempt to make the timeline more relevant is working. Of course, it also means that for success, that sponsor needs to listen, to hear, and to act on the feedback that we've been given. We can only provide the feedback.
Excellent. And I was really interesting to read that one of your groups, Independence, has become maybe the first major insurer to cover next generation whole genome sequencing for a variety of cancers. And when you were saying about evidence and outcomes, we know from our meeting that the diagnostics field is very much linked with these new advanced therapeutics in cancer. Do you expect the resources that Blue Cross is applying in covering a lot of these genome sequencing is going to be a common trend for the healthcare system in the US?
I think what I would like to focus on are some of the prerequisites here and some of the things that are really important to appreciate, both in testing in general, as well as the molecular diagnostics in cancer and the broad whole genome sequencing that is now being used in molecular profiling of tumors. And I'd just like to talk a little bit about testing and some of the dimensions of testing that I think are really important. And I will note that this is a gene therapy titled conference, but you know, underpinning all therapies are good tests. And I say tests because we often say diagnostics, but tests can be prognostic, they can be predictive, they can be diagnostic. So, and I think we need to have a broader appreciation of how important a good evidence foundation and a good quality of testing is for the success of any therapy. And I think we often underestimate the impact of tests. So as we look at this, we really are encouraging. And I very much think of Dan Hayes' work for ASCO, where he talked about when you evaluate tests, you have to think of them as therapies. Now, I understand for many test companies this is anxiety producing, but there are many settings which indirect evidence, that is made inferentially, can suffice. Not every test will require a trial, though some will. So that is one element that we need sound evidence on. The reproducibility of tests, sometimes referred to as analytic validity, the ability of tests to to accurately call the presence, absence, or likelihood of a disease or condition of interest, and then what's often called the clinical utility. What's the use of having that information? How will it change management, and will it make things better? Which it can only do, of course, if it's accurate, reproducible, analytic validity, and clinically valid. So that is a point of great emphasis, and we are beginning to appreciate how important that analytic validity is. You know, it's in some ways the most technical part of this whole paradigm, but if that test is not reproducible, and labs are not reproducing it, and labs are not selecting the appropriate person for therapies, then the efforts that sponsors of therapies, developers of therapies, clinicians, and the expectations of patients will be disappointed. And I've been really excited to be part of a pilot program that Tapestry Network has been facilitating it. And you can read about it on their website, but there are multiple stakeholders, regulatory, from oncology therapies, from testing groups, and this pilot will actually produce will contract for to very exact specimens, reference samples, and there will be volunteer laboratories. It is focused on companion diagnostics, and it is one singular coming to market companion diagnostic, but that's because it's a pilot. And what we're really looking for is the ability to show that you can, in fact, determine laboratory quality. You can make sure that when Lab X says patient Y has genetic variant Z, that if you go to different places, you will get the same answer. That is fundamental to the success of these therapies. So my first point is, don't forget the tests. They are the platform in which your success in delivering a therapy is based. You cannot deliver on your promises unless those tests are sound. And we need to be looking at them in a very evidence-based way. My second comment is what we call personalized medicine or precision medicine. I myself has always preferred the term stratified medicine, but because I think it actually gives us a more realistic sense that these are dimensions that interplay and not necessarily unique features, but that we're moving into multiple variables. And you probably saw The Emperor of Maladies when it was on PBS, and I was very struck there, especially the sections on the viral theories of cancer, and then again the section on the high-dose chemotherapies with stem cell transplant, and I was very much involved in some of those discussions. And what struck me here is our tendency to overgeneralize. I mean, cancer is not a single disease. It is a very, it is a single term for a complex multiplicity of conditions and behavior of conditions. And what really struck me was the tendency to see one approach that has worked very well in a defined setting, being seen as the universal answer to cancer, which is actually not one setting, but many, many complex settings, even within what we call a single disease or diagnosis. And I think the effort with the targeted therapies that exist, to use them off-label, using tumor profiling as a tool to select a therapy, it's had somewhat limited success so far. The situation, and this is always true, seems to be more complicated than first assumed. The presence of a gene is not necessarily the driver of the tumor. There are bystander genes. You can find some of those variants in normal cell tissues. It all is more complicated. So I think my second comment on that is it seems to me, in my opinion, that we are unlikely to find a single answer of a variant that is driving every therapy, and that other paradigms will evolve and it will be more complex. And of course, we can't just think of the molecular diagnostics, we have to think of the patients who bring with them their own comorbidities, their own history. These will, of course, have some manifestation at molecular level, but to me, the stratified medicine or precision therapy is also about that patient as a whole, not just their molecular features. So those are really my two comments with reference to that. And with respect to the resources, I think resources follow the evidence. And I thought one of the points made here is how the degree to which next generation sequencing has become so much cheaper. And that is absolutely true, but I will also leave with the thought that it's not just the test, and it's not just the cost of the test that is the resource, it's the cascade and what happens afterwards. And if we don't have that analytic performance and that reproducibility of the test, and we don't have good prediction of the presence or absence of disease, and we don't know what to do with the information, then yeah, we're going to have a lot of unnecessary cost from that cascade.
Yeah.
So our attention, I think, needs to be not so much on the tests per se, although they're very important. And as I've described, we have to give them more deference in the sense of thinking them as integral to therapy, but also the cascade. And that refers to the clinical utility of reliable information.
Excellent. Thank you very much. I think we've that's everything I wanted to ask. I was going to ask another question, but I think you kind of talked about the resources, and that was excellent.
Good.
No, thank you very much.
Thank you very much.
Yeah,
My
great.
pleasure.
Right.